So thanks so much, PMD Alliance, for continuing to host and having this great space where we can all connect. I think as things are opening up, I hope that people are getting out and into nature and out into socializing. As you know, I have spent a lot of time trying to get people to socially connect. So that is definitely the priority. And so if you're watching this later on video, welcome as well. And love all the new technology. I can't keep up with Facebook Live, YouTube Live, all these lives, but the more the merrier. So it's always lovely. And so in celebration, and we're just sneaking it in at the tail end of Pride Month, I am so excited to host our guest today, who is Dr. Jason Flatt, who is joining us from Las Vegas. He's at the University of Nevada in Las Vegas, and he's an assistant professor there who really came highly recommended by Zoltan Mari, who's a close colleague, and we've been collaborating on a number of initiatives around mental health, social connection, and also disparities. And so really trying to help with improving the care of Parkinson's patients around the world, and all people living with Parkinson's and their caregivers and all the people that love them, helping to enhance their lives in whatever way we can. And I think the pandemic has really shone a light on how we've not been doing things well, and who we have not been serving. And so it's been my mission in 2021 and beyond to try to help get the best, the greatest, the minds to sort of work with us to help improve this cause. And so I welcome Jason so much. He found the time this month. He's been very busy. And maybe Jason, you can tell us a little bit about yourself, a little bit about your background, why you've been starting to dabble now more in Parkinson's disease, and really come from a background of taking care of dementia folks and Alzheimer's disease, but really starting to teach us in the Parkinson's world how to do this better.
Absolutely. Thanks so much, Indu, for inviting me today, and for me having the opportunity to share a little bit about my work. A lot of this really stems from my work. I've been focused a lot on LGBTQIA plus populations in terms of thinking about neurodegenerative diseases, specifically dementia, right? And really seeing unique challenges around, do we know if the community faces differences in risk? We're still not quite sure. Some studies are saying yes, we see greater memory problems, we see greater subjective concerns, we see challenges with disabilities, right? Physical function, motor function, things like those are concerns. And what we're finding right now really is around sort of the lack of access to caregiving support. So we know, for instance, the community is less likely to be married, likely because, marriage equality didn't even happen until 2015. There's also issues around many members of the community do not have children and were not connected to their biological families because of discrimination and lack of acceptance of their identities. So we know that if the community a member of the community develops Parkinson's, they're going to have unique challenges in accessing their care, in remaining independent, right? And even finding some of the innovative care that's out there that could help them better cope with the disease. So those are like really big challenges. And I was in San Francisco interviewing LGBTQIA plus seniors and really learned a bit about the historical challenges, but even we're still seeing today discrimination in healthcare settings, right? Misgendering, not inviting chosen family to be a part of the care decisions. So we know that these are going to be concerns for our community that are living with Parkinson's. So that's really what's been driving my interest in this work.
That's amazing. Well, I know that you put together a little bit of slides for us as well, so I'm hoping you can share those maybe with us, and
let me do that. And I always have an issue with showing you my notes, but we'll see if I get it right this time. All right, let's put it in the full screen. Do you see the right one, or are you seeing my notes?
We're seeing, yeah, maybe just put, can you go to,
Like that?
yes, there you go. Perfect. You got
Perfect. Okay. Well, thanks for having me today. And I'll give some little shameless plugs for myself of I have a research program. You can find out more at rainbowsofaging.org. And as Indu had mentioned, I'm at the University of Nevada, Las Vegas in the School of Public Health. So I wanted to first start off with just getting us on the same page in terms of terminology, right? And so you're going to hear different terms in this space that are used. So for instance, some terms we sometimes use, especially with work funded through the National Institutes of Health, back in 2016, they designated LGBTQIA plus people as a disparity population that experiences unique health disparities compared to non-LGBTQIA plus people. And the term that they've been using to represent that is sexual and gender minority, right? And so it's important to emphasize that people can be one or the other or both, right? Because these have really two different key differences. The first one has to do with a person's sexual identity, how they self-identify. So they may identify as gay, lesbian, bisexual, queer, asexual, or they may use a broader term where they feel like those identities don't represent sort of their identity. But we know that typically in how they define their sexual orientation, it would differ from that of heterosexual adults, right? People that are attracted to people of the opposite sex. Then we use the term gender minority to represent people who self-identify as having a gender identity that differs from their sex assigned at birth. So this could represent transgender people, people that identify as genderqueer or non-binary. It's representative of people whose identities, their gender identity, their gender expression differs from that of sort of the social and cultural expectations of sex assigned at birth, which is still mostly represented as binary, male or female. But even some of my own work has been showing that sex assigned at birth shouldn't be binary. We actually know that there are people that are born with differences in their sexual development, in their anatomy, as well as their genetics. So we are using the term, right, intersex people. And so we know that really we need to move beyond that to be more representative of a spectrum of identities. You'll also hear me say the term cisgender. And what this represents is people whose gender identity aligns with the sex they assigned at birth, were assigned at birth. So for instance, for myself, I identify as a gay cisgender man, right? So I was assigned male when I was born, and I still identify my gender identity predominantly as male. It's also important that we acknowledge, though, that sexual orientation and gender identity can evolve over time. And so it can change over the lifespan. So a lot of people think, oh, it's static and you can't ever change it, but that's actually not true. Just as we're seeing terms that are used in sort of this broader acronym of LGBTQIA+, we're starting to see culturally shifts in additional terms that are used to identify subgroups in the community. It's also really important that we think about gender and understand and acknowledge that gender's under a spectrum, right? In terms of sort of this range that encompasses people's gender identity. So you can see here this great image from the Trans Student Educational Resource that shows this gender unicorn, right? And shows you gender identity can be across a spectrum, as well as our expression, as well as the sex we're assigned at birth. And then when we also think about this, we also can see a sort of a spectrum in terms of who we're attracted to physically as well as emotionally. And so I wanted to emphasize there are a range of terms that can be used to encompass sort of the diversity in terms of gender identity. So I wanted to move us over to kind of thinking about why should we be thinking about LGBTQ plus older people? And a lot of times there's been sort of this misconception that, oh, aren't LGBTQ plus people better off? And that's not actually true. It has to do with biases and recruitment that we've seen in research and studies traditionally. But what we're seeing right now is there's at least over 1 million people in the US who identify as LGBTQIA plus and who are 65 years and older. We also know in terms of intersecting identities that our community is extremely diverse. So here I'm showing you that approximately 1 in 5 members of our community are a person of color, right? So when we think about intersecting identities, there can be additional challenges in terms of structural discrimination against minority people, right? And that can create unique challenges. And we have to be thinking about that when we're working with our community. We also know that there are some really unique challenges for LGBTQIA plus elders. And then now think about if you add a neurodegenerative disease to that, like Parkinson's, how it can make it even difficult to remain independent and have a high quality of life. So we know, for instance, more likely to be single, right? Also, they're less likely to disclose their identities when they go to seek care. And this is because of historical discrimination, but also current discrimination. So we know, for instance, in the past, identifying as a homosexual was considered a mental health disorder. And we still see concerns with this with our transgender community, where they're still diagnosed with gender dysphoria, and that falls under a mental health disorder. When we think about care for our community, it's also important to realize that there are economic and social challenges, right? I show here at least a third of our community is living in poverty. And then we also see that they're more likely to live alone and be single, which creates unique challenges in accessing resources. So our community, given really the historical discrimination, the structural discrimination that's experienced, our community faces unique health disparities, especially when we compare them to heterosexual cisgender people. So for instance, we see high rates of suicide in the community when we compare them to other groups. We see greater rates of disability. We also see other challenges. And again, it's important that we don't blame our community for these challenges. These are really the result of policies, practices, right? Our social environments that have not been welcoming to LGBTQIA plus people for quite some time. So this highlights, and then when we think about intersection with other identities, right? If you're trans and gay, or if you are a racial ethnic minority, those can also be compounded and you could experience additional challenges. So it's important that if we're going to do work in this space, that we acknowledge this. But I also want to acknowledge, yes, we face challenges in terms of health, but we also have amazing resilience. And so I wanted to just do a special shout out and share with you a little bit about why we celebrate Pride, right? And it's really about our community coming together and advocating for our rights. For instance, I know today I would not be able to be married to my husband without the work of our elders driving these changes. So the reason we celebrate Pride in June really has to do with our pioneers who fought for equality. The reason specifically that June is Pride Month has to do with two of our unique trailblazers, Marsha P. Johnson and Sylvia Rivera, who were in New York City the early morning of June 28th, fighting back against police brutality, driving this change. So you'll hear about the work at the Stonewall riots, right? The Stonewall Inn. And this is when they finally fought back. The police continued in the past and raiding bars, raiding LGBTQIA plus safe spaces, incarcerating people, and attacking the community. And this was the time that they stood up and really started to fight back against this. And we saw this happening across the nation, right? In San Francisco, we had the Compton cafeteria riots. We also saw work happening in LA where the community was really fed up with the discrimination and brutality. So this is just a quick snapshot of some of what our trailblazers have helped us to do, starting with the Stonewall riots, right, leading to the development of the LGBTQIA plus rainbow flag, as well as you seeing in 2015 where we were finally legally recognized for same-sex marriage. So before I have my discussion with Indu, I just wanted to also highlight as a responsibility to us in working in the community, we need to give back, right? So that's paying people for their time, right? Giving money to organizations and supporting our community, right? But also showing up for events, right? Showing up for the community, showing up for each other. If we're going to continue to bolster our community and help them to thrive, we need to give back and show up. So I just want to give a special call out to that. Just acknowledging I have no conflicts of interest, and I do have financial support from the National Institutes of Health, the National Institute of Aging, and here's just, again, my contact info, but I'm going to stop sharing so Indu and I can start chatting a little more about this.
That was awesome. Thank you so much for clarifying those terms. I think they get, increasingly a little confusing to folks, and I think people in the chat were resonating with that confusion, but it's always good to clarify and understand a little bit about, where these terms came from. Also clarifying, why we celebrate Pride Month. And I think it is a celebration and some amazing strides that have been made by an amazingly resilient community. And I think, when we think about those who are not served, there are a lot of folks in the Parkinson's world that are not served. And I think sometimes when it's like a percentage of a percentage, people feel very alone and they feel like they don't have the ability to stand up and say, hey, help me or help my community. We are not being heard. We are not being cared for. But I think when you sort of take an intersection of all the people that aren't being served, there's a lot. So hopefully we can work together to improve, the sort of racial sort of piece of it, the, sort of the gender. I think there's a lot of women that feel that their voices are not being heard as a minority. That is, huge. And then, the LGBTQ community as well. I think, sort of thinking about how to draw parallels and success stories and sort of take from, other disease states sometimes, like, I think you guys have in the Alzheimer's world done some remarkable things, including putting together a conference recently that I saw highlights of, and how, you guys were able to organize. And even I think the community, I've always, been tremendously in awe of even, the HIV movement and sort of getting a lot of folks together fighting against discrimination on a regular basis and sort of, coming together so amazingly well during that time frame. And a lot of the folks that have lived through that time frame are now aging and now getting, into these sort of time frames of being more at risk for the types of issues that we're talking about, Alzheimer's disease, Parkinson's, and things like that. So maybe, Jason, you could spend a moment maybe telling me a little bit about sort of the history of that, maybe HIV time as well, and AIDS movement, because I think it helps us put a context of sometimes even the trauma that's been faced by this community, of gay men and also the people that have, rallied around them in other sorts of LGBTQ, and so it may help us contextualize how to care for these populations as providers.
Yeah, I was really honored during my time in San Francisco to meet a lot of the advocates and the long-term survivors of the HIV AIDS epidemic, right? And we know that specifically this decimated specifically the gay male community or men who have sex with men, right? They had lost, I mean, in a matter of years, just everybody. And at the time, really, this was during the time of the Reagan administration, they were pretty much ignoring it, right? Not really talking about it. I even heard at this time they were restricting funds or cutting back in terms of CDC and NIH funding. So what really had to happen with the community was they had to rely on each other. They had to turn within, right? People did not, because there was not funding to support, people didn't understand what was causing HIV at the time, right? They didn't know how you could contract it. All they knew was that it was occurring more among gay men or men who have sex with men. So there was a lot of fear. There was also a lot of discrimination against people who were, at the time, we didn't have medications or drugs to help prevent it, right, as we do today. And really, this was such a difficult time. So the community really turned within. They relied on their lesbian community members to provide care. They relied on their fellow friends. I talked a bit about like chosen family. So it really was around relying these grassroots efforts to rely and build your own community, your own networks to protect each other, but also, you know, to help people deal with end of life. There was a lot of fear, there was loneliness and challenges, but from that came massive losses, right? Massive losses, but also resilience in the community. It did bring people together, though it was a very traumatic time. And it's important that I've heard from LGBTQIA plus elders right now that even getting through the current COVID pandemic was a triggering for many people around, oh my God, how's this disease spread? We're constantly hearing in the media, people are dying and we don't know what's going on. So just imagine if you had PTSD, which many people did from the HIV AIDS epidemic, this was a triggering event that we all had to deal with for nearly 2 years. So very difficult. But I think what it showed to us is really that we have to turn within and bolster our community, rely on our strengths and help each other. And I think we can bring that to Parkinson's disease, right? That's really what we can be thinking about is how our community, the strengths that they have developed, we can tap into those to support people as they're getting older or living with a disease like Parkinson's.
Absolutely. I mean, Nirav writes that Dr. Dorsey actually was talking about how the HIV activists really weren't polite when they were trying to be activists, and they were putting condoms on senators' homes to get attention. But, I think sometimes when push comes to shove and you feel unheard, and I think, many people in the Parkinson's community feel that this is, a pandemic of Parkinson's, and that ever expanding numbers and affecting more and more communities, younger people, and that we need to kind of resort to measures that are a little out of the box. So I think that we can, put our thinking caps on together and think about how to engage. But I think the idea that, gay men are relying on lesbian women to support them is really a smart, move. And I think, people who feel like their voices aren't heard. I think we have to really, as advocates, try to come together across these silos, rather than saying we want, for gay men, we want more pieces of the pie. Let's think about, who has the biggest piece of the pie, and everybody else try to get together and figure out how we can,
You're talking about privilege, right? We know that there's privilege even in the LGBTQIA plus community, right? And so people that have it need to step up and share it with other members of the community who may be facing unique challenges and don't have access to the same resources that others do. So, and I always like to say, I think of improving care from more of this person-centered approach. So if we improve care for LGBTQIA plus people, it's going to end up improving care for everybody, right? It's about meeting people where they are, acknowledging their history, acknowledging their identities, not making assumptions, and this continual kind of dedication to learning and being humble, right? Humble when we're working with our communities to learn more about their needs and how we can leverage the strengths and support them.
Absolutely. There's a question here just in the humility, because I think, we're all here to learn and I'm
Yeah,
learning about all these terms. So Mary asks about the pronouns.
yeah,
Can you teach us a little bit about the pronouns and what they mean?
yeah.
And
So
yeah,
pronouns have to do with an individual's gender identity. And so, again, there are a lot of assumptions that are made when we visually look at someone, or we read their name, or we make assumptions, right, about their gender, right? And so, typically, we live in a world still where the most privilege is held by white men, and typically, there's been a standard in all of the work that's been done where we just follow this binary she, her, hers, he, him, his, right? And make assumptions about people's identities. And that's really inappropriate. And we need to understand that gender identity is diverse, and we should be using terms that come from the people who are accessing our services, who are in our community, right? So it's things like not making an assumption. We think it's very respectful to be like Mr. or Mrs. so-and-so, but we even don't know necessarily about if people are married or not. So we sometimes make assumptions that way. So it's important to, in the work that you do, ask people first their name, right? The name they want you to use. So it's not necessarily just going over what's in the medical record or what's on a form, right? And making an assumption that that's what they would want you to call them. I think about the fact that some of us don't even use our first name as our name, right? We may go with a different name that we prefer to use on a regular basis, and that's our name. So it's asking people's names. It's on our forms, assessing questions about gender identity, right, that are inclusive and following best practices, and using the pronouns that people want you to use, right? So that's either referring to them by the name they've asked you to use or asking about pronouns. And if you make a mistake, it's okay. I talked about humility. It's about learning, about openness. So it's quickly correcting that mistake, right? Saying, if I make an assumption for you, Indu, and say, she wanted me to come today to talk, right? And you're like, that's not the term I use. Then I should be asking you, and I asked this before we even started.
yeah.
I wanted to know your pronouns so that I didn't misgender you. So I think that is really important, and we make it a common practice in everything we do in our patient encounters, in our encounters with the community. Use the pronouns that they ask you to use and don't make assumptions.
So basically just say, what would you like me to call you by
Or
what
not
name?
even that, right? What do you
And
say
then
when you
what,
meet a stranger? Can you tell me your name?
right.
Right? And then you just use that name,
Okay.
right? And if you are in a setting and you feel you're at some point going to use pronouns, but usually we don't. If we're talking one-on-one, we usually use them more in third person. But if you do encounter it and you start to make an assumption before you say it, you can ask, right? Can you tell me your pronouns? I go and give yours. I I use she, her, and hers, right? And that can be a way to open that conversation. It's
Okay.
about not making assumptions, really
Sure,
is the
sure. No, absolutely. I think that's great. And thank you for explaining that.
yeah.
So Anissa writes here, how can we better serve? In the past, I've tried to partner with the local LGBTQ plus community with their aging members and could never get it off the ground. There's a need, but how do we better meet it? And then Christopher writes, great question. He said, as a queer service provider, I remain at a loss for how to best outreach to our various communities. What are the rates of LGBTQIA folks who have been diagnosed with PD? How do we best raise awareness to a condition that may not be prioritized or visible within our communities? And I think, when we're talking about these two questions, I think we can also, just talk about the fact that there was one of the first papers that I ever saw in the space that was just written, and I think it was in Parkinson and related disorders, just identifying the gaps. But I think this 2021 is like the year of identifying so many gaps in so many spaces. In fact, there hasn't been a great gaps paper even for women with Parkinson's disease, which make up, a large percentage. So what would you say, Jason, as sort of some thoughts on these 2 points that were made?
I think, and I had shared this a bit, it's like show up, right? So if you want to include the LGBTQ plus community in the work that you're doing, go to their events. Ask to be invited to community events, right? Show up and go. Offer opportunities to learn from them, but for you also to share what you're doing with them, right? It's building, much like we see with other aspects when we're recruiting minority populations, it's about building relationships, being transparent. So sharing, why are you there? If you're there because you want to promote your clinic and you have some great services, right? That's going to make you money. So it's important to be like, we want to tell you about our clinic. Here's the service we offer. How can we accommodate people that may have income challenges? Make sure to bring that up, right? It's about really being open and learning, making your spaces welcoming. One of the big recommendations I have is if you want LGBTQIA plus people to use your services, you should probably have hired some LGBTQIA plus people. We want to see people from our community accessing your services, working there, right? We want to interact with them. So it's important to really think about how can you shift the culture in which you are working at or living in. How can you make sure that it's welcoming and inclusive? And then that second question about Parkinson's disease, we don't know very much. That's because most of the research has not been collecting information on sexual orientation and gender identity. And so that's why we need to follow best practices and collect that. We won't know about the needs of our community if we don't ask. And so that's been the major challenge. And so we're hoping some of what Indu and I have been talking about is how can we start increasing sort of that work in the field and making sure that LGBTQIA plus people are represented in the Parkinson's research and service work.
Absolutely. Yeah. And I think, there has been a push recently for grant applications, and we're really excited to, be involved in that. I think in many institutions that people have been hungry, our patients have been asking for this. And, I think for folks who are doing this type of research, it's been kind of, kind of a pet project, sometimes a labor of love, but, to have hopefully 2021 really focus on this more, to literally honestly meet people where they are is such a focus of what I am wanting to do, moving forward, and really thinking about that cultural context of what are people living around every day, and how does then that influence how the Parkinson's disease manifests in them with the motor, non-motor mental health issues, even connecting socially, and how to help people prepare for their futures too. When you give them this diagnosis, it has never made sense to me that we just have, male, female, sometimes asked. We then go on to a range of motor symptoms, tremor, stiffness, hand out pills, and then see people in 6 months and not really care about much of this until, once people start to sometimes really have cognitive changes or many years into diagnosis, and then are woefully ill-prepared for what is in their future, which is sometimes the need to engage people rapidly, suddenly to care about them and include them in their diagnosis, and then also in their future planning for, long-term care or whatever, even advanced care planning, palliative care, all of those things, I think culturally can be very different in different communities. And if no one tells you that this is what you need to be doing, I guess, it's not, sort of intuitive. So what have we learned from the Alzheimer's community in that regard? I think, I just mentioned to Jason that I've been spending a lot of time talking to women as well with Parkinson's. And, if you're if you're a married woman, the caregiving needs are very different. And the people who are caring for you, if you don't have a wife and are affluent and white and male and educated is very different than, even many of the populations that we're trying to serve. So women who are married sometimes end up divorced, and then even women who may not have a life partner end up being single and needing to make the same sort of thinking about their family, who is their family or who is their sort of social support. I think some of the things that we were talking about with the LGBTQ plus communities may sort of be also resonating with them too. So maybe teach us a little bit about what you say, how do you help prepare people, and what are the community resources that you've been able to engage in this population?
Yeah. So I first wanted to touch on sort of that point that you said about for women. And I think it's important that we acknowledge the historical oppression and current day discrimination, structural, institutional, all of these pieces towards women. We know women do not make the same wages as men for doing the same job. That's not right. We know that women haven't had the same rights as men historically for quite a while. And yes, you're right, they're burdened with much of the caregiving demands, right? It's an expectation that women provide caregiving, and these expectations come from society as well as the systems and the structures that have been developed, right? So you're absolutely right that they face unique challenges. I'm doing some research in that space actually with Dr. Shana Stites at University of Pennsylvania to look at historically how these aspects impacted women's risk for dementia. So hopefully we'll learn some more about that. And so we're looking at things like employment, educational opportunities, caregiving demands, all of those aspects that could affect someone's health over the life course. And we know that those are unique for LGBTQIA plus people as well, and people of color. In terms of like resources with the community, a lot of my work has really been focused on leveraging some of the community organizations, service providers that are really on the ground meeting the needs of our LGBTQIA plus elders. So the first one is SAGE, Advocacy for LGBT Elders. It's based in New York City, but there are many chapters across the US. They provide a lot of unique programming. We also have been working with some of the local groups. So for instance, I've worked with a group that focuses on affordable housing for LGBTQ plus older adults in San Francisco called Open House, as well as the Los Angeles LGBT Center. They have a senior services division, and they have housing at Triangle Square, and they're getting new housing. New York has housing. I'm working with groups here in Las Vegas. So a lot of it is around tailoring support, right? Finding, so we just had actually the Human Rights Campaign, and SAGE just came out with one of the first reports. They usually do that Health Care Equality Index. Well, the index just came out for the first time ever for long-term care, right? So it's finding those kind of pieces, and I'll post that into the chat in a little bit. I'll go and find the link to it. But I think it's around really leveraging the resources from our communities, working with organizations that really their core mission is to serve LGBTQIA plus older people, and really bolstering kind of the services and interconnecting the work. So that's sort of how I've been working with the community. There's also some national like organizations through conference, some professional societies. So I've been working on some of that as well. I saw someone posted about support groups for people with Parkinson's. I don't know much about that. Maybe someone here is aware of one. I believe there are some. I know the Alzheimer's Association's been starting some support groups for LGBTQIA plus people, but I definitely think we need to do more of that in the Parkinson's disease space. It feels like we're just at the beginning, and even the questions we haven't answered in Alzheimer's disease, but we need to be getting some more momentum when we're thinking about Parkinson's.
Absolutely. I mean, because in Parkinson's, you also have, in Alzheimer's, there's a relatively, the cognitive realm, but in Parkinson's, just, a lot of other domains as well. So if you had somebody before you, right, and you're giving them a diagnosis of Parkinson's, and you have talked about, what is their gender, what is their sexual preference and things like that. And then you get a sense that they are, let's say a single gay male, him, her, that is not really, sort of connected to a community, sort of folks. And also, you're sort of trying to give them a sense that they don't bring a family member. You ask them, who's in their family, there's really no one. What would you tell somebody like that? How would you tell them, even early in disease, to sort of behave so that they may be able to prepare for their future?
I mean, my strategy would be more of finding about, it's this person-centered approach, right? So finding out about their unique needs, their unique concerns. And as part of the work that you're doing as a clinician, it's identifying resources, right? So I wouldn't want anyone to leave my office and not have somewhere to go to get help, whether that's their local LGBT center, whether that's a SAGE affiliate site, whether that is referring them. We're seeing in the chat, right, these different support groups that are coming up, this Parkinson's Buddy Network at Michael J. Fox, right? So it's about like giving people resources to utilize so that we don't want them leaving our office and not having anything to support. And if we don't give them anything but a diagnosis and some meds, we might never see them again. So that's going to be a huge loss to them. So I think it's, building this connection, this rapport, changing the culture in your office, in your clinic, and ensuring that you connect people to resources. They shouldn't be leaving with a diagnosis and have no clue what comes next, right? So if that means having a social worker on staff to help people get connected, or referring people, right, to services, that should be a standard part of the process.
Absolutely. Yeah, I mean, I think we have not done a good service with this at all. The other thing that I will say is that sometimes, just targeting on, sort of the experience that people bring to the disease. One of the things is that, what has been shown in some cognitive change, disease states, is that trauma or even racism or things that have happened to you in your lifespan may actually affect how you then progress as you've gotten a diagnosis. And so I think it only helps us as clinicians to have a sense of these, what the person is, where we're meeting them and what they've experienced to date, so that we can kind of help connect. And I think a lot of clinicians feel overwhelmed, where we're sort of have a 15-minute visit. I'm wearing a white coat, somebody comes in to see me, I have to do a lot, and then I'm sending them back out. But I think we, as a community of people who care about people with Parkinson's, living with Parkinson's, are going to need to harness other resources. And I think the pandemic, as tough as it's been, maybe we'll have, as you mentioned, kind of rising from the ashes of the HIV sort of epidemic or pandemic or whatever we want to call it. There was some really amazing things that came out of that, I feel like, as a community. And I think we have an opportunity to hopefully connect some dots here. And I'm really loving, honestly, the sort of camaraderie of seeing the Parkinson Foundation, the Michael J. Fox Foundation, the PMD Alliance, and whoever else is on the call here, all coming together to realize that we are doing a disservice to this population. And so anything I can do to help, with this, and I would love to. And it sounds like there's a big interest across, sort of this group as well. So, and maybe even, we have an opportunity here at the PMD Alliance to start a discussion around starting maybe a support group. It sounds like maybe here. And also, I think the Parkinson's Buddy Network is exciting in this sort of concept of social prescribing, which is sort of what you were talking about. It's sort of like meeting people where they are in the community, identifying their needs, finding ways to support that person, almost like a prescription, either connecting them to other people, other support services, other existing networks, and then trying to harness that, to sort of improve their holistic health, which this obviously would fall under. So I'm all about.
I think caregivers should be a strategy too, because we know if you are a caregiver, and I've already talked, and you're a chosen family member, you're a neighbor, you're a friend, you might be a roommate just renting a room in someone's house, and they need additional support, right? And so it's like but caregivers need support too. When you're caring for a loved one, I have stories, right, where like certain institutions, people are afraid about having to go back in the closet if they go into a long-term care setting, right? Hiding their identity, right? And not being able to be themselves, being separated from a partner or a roommate or someone that is very important in your life, right? All of those pieces need to be considered. We need to be thinking more about the holistic aspects of the individual and not just, right, the diagnosis and potential medications. We need to be thinking about how's this going to impact their social life, their job, their ability to remain independent, their ability to be connected with others. Like all of these need to be addressed if we want to really promote quality of life, but give people the best opportunities and resources to be themselves and live a fulfilled life.
Absolutely. Ruth read something about the word queer. Maybe you could
Yeah.
clarify that for us. It sounds like she might have gone to a workshop where the queer was not good in the in the community because it
Hmm.
triggered people's horrible life experiences. So maybe is that a reasonable thing to use
Yeah.
still, or what's your sense of that?
So I think it's important to ask, right? When you're doing work with groups and thinking about language that's affirming, right? And so if queer is not a term that the community wants you to use, it's important to realize that. Other examples people have, so for instance, I have a very close friend who is 77 years old and who's transgender, and she continues to use the term transsexual, right? That's how she identifies, that's the identity, but that term is not commonly used in younger generations anymore. And some people view it as stigmatizing. So I think it's adapting your language to what would be inclusive. It's that humility, right? We're never going to completely get it right, maybe off the bat, but I think it's like being open and learning. And if you're forming a group, right, and you're hearing, we don't want you to use queer, don't use it, right? Or have a discussion around it. What is the meaning of that term? Why is it sort of traumatic for people? What are language or terms that people might use? And that was feedback I got when I was creating like my research program, and I call it Rainbows of Aging, so that it doesn't have any stigmatizing language that might trigger someone. So I think it's just about forming an identity with a group and using terms that they connect with and find affirming.
So yeah, absolutely. I think asking people, how they would like to be addressed, the pronouns. I mean, I'm learning a lot. And I think so. So I think, in Wissam's paper and Dr. Deeb's paper with a few other folks that just came out, there were sort of these three main domains sort of needs. One was research, one was policymaking, one was education. We've touched a little bit about the education. I think, just having this as a resource. Maybe if you are, in this community and people are not addressing you properly, sharing this sort of link to this chat it would be great, because I think I've learned a lot about even,
Mhm.
so many things. I think, these basic things, I think, go a long way. Like you said, hiring people that are in the community so that they can also educate and welcome people in the space. Maybe if you're running a support group, asking about these things, identifying this, putting your own pronouns in, maybe if you're in Zoom, and making this sort of an accepted custom, I think would be very reasonable. What are some other things from an educational thing that we can maybe try to do,
I
Jason?
mean, it's much like we think around like trainings for our staff, right? On cultural humility, on how to change the culture to make it inclusive. So it should be that way for the staff. It should be that way for patients. It should be that way for the clinicians, right? It needs to embody the whole environment. And so it's basically providing training, sensitivity, writing policies, right? If it should be included, if you have non-discrimination policies, it should include people's sexual orientation and gender identity as part of that. It's practicing what we preach, and just being open to ongoing learning, right? One training isn't going to do it, right? It's got to be a regular part of what you're doing. Education wise, I think it's also working with community groups, right? To leverage some of the strengths that they have, the training they could provide, the support, the referral, so that you could work with each other. So I think it's a, it's really, again, this broader, like, shifting the culture to be welcoming for everybody, right? And making sure that there's opportunities to get feedback, to check in about it, to hear from the community, so that way they do feel welcomed and a part of it. If you have events, it's inviting the community to those events. It might be showing up to events that you're invited to, right? I this week had a grand opening for our Trans Pride Center in Las Vegas, and I made sure to show up. I made sure to invite political legislators and be like, you should come to this. Use any privilege that I have to advocate for the community. And so I think that if people do that, we will make changes that improve the lives of everybody.
Absolutely. Yeah. And I hope it's sustainable too. I mean, I think, when the George Floyd incident happened, I think there was, a lot of, focus. And I think
Mhm.
that there's been, a Band-Aid that's been ripped open a little bit. But I do think that, it's 2021. I hope that, this is still on the top of the agenda for
All
everyone.
should be vote. There's the Equality Act that's going to be coming, being reviewed by Senate soon. So we should be advocating to our policymakers to support that bill. That's a big national step. I think it's looking at things that are happening locally, but also in your state. For instance, we know right now there's like at least 33 states in the US that have been bringing forward discriminatory laws against transgender people, right? Not allowing transgender people to use the bathroom that they want. Why do we care what restroom someone uses? That's nobody's business, right? And why should we be restricting that? The next piece is not allowing transgender youth to participate in sports. What is that about? It's ridiculous. And then there's been laws being passed that are not going to allow people to access affirming care, right? Blocking people from getting trans affirming care, that's not appropriate. So if you see opportunities to advocate in your state, to change institutional practices, that's what we should be doing, right? That's how we're going to create change that's long lasting. Like you've mentioned, we need one to take charge of the momentum we see right now, but it's a continual thing. We can't stop. It needs to, in order to improve care for everybody, we need to be addressing these structural issues.
Absolutely. Absolutely. We have about 5 minutes left,
Yeah.
Jason. So I wanted to give you an opportunity for sure to, talk about anything else that you wanted to focus on. And I know you had that meeting that was like, sort of a symposium for Alzheimer's disease. Were there a couple of things that were really like exciting to you that we can take away from that meeting? Maybe think about a meeting
Mhm.
such as that for Parkinson's as well. What's your sense of them?
Yeah, this meeting was like super exciting in terms of right, focused on really the research that's happening in the LGBTQIA plus dementia space, right? And some things that stood out to me were like, we're not collecting data, right? So again, that issue of we call it SOGI, sexual orientation and gender identity data. That needs to be a common part of your assessments. If you're doing research and collecting information on people's backgrounds, you definitely need that. You're not going to be able to help people if you don't know about their unique needs. And so you need to be asking those questions. That came out. We had several panels that touched on work around caregiving. I haven't seen much in the Parkinson space around caregiving for diverse communities, and especially LGBTQIA plus. So we need more of it. We need to be understanding the needs. We need to be taking evidence-based interventions that we know that work in Parkinson's and adapting them so that they're culturally acceptable, right? So, and we need to test it using science to make sure, is it actually working? So that's a piece that Parkinson's should be thinking about. The big piece is we don't know about the needs of our community. So we need research. We need to advocate if there are national surveys, population-based surveys, anything that's out there that they're collecting information on sexual orientation and gender identity, right? We're not going to be able to learn about that unless we advocate for more research. So it's really exciting that we're starting to see more of this happening. I hope I saw in the chat people saying, can we get all the groups together that are focused on this, all of the neurodegenerative kind of research areas, and let's bolster this so we can support our community. And I completely agree. That's some of what we should be thinking about. And I hope that today, and as we continue to progress, right, that we keep thinking about how can we advance both understanding of Parkinson's disease risk, but also improving care for the LGBTQIA plus community. That's what we need.
Absolutely. Well, I think, my take homes are that we should maybe break down the silos across disease states, maybe, focus on the brain and LGBTQ or something.
Absolutely.
Second is, to sort of break down the silos even of our groups across Parkinson's disease, people living with Parkinson's, sort of have all the sort of people that aren't getting care come together, no matter who you are, person of color, woman, whatever, and understand that, culturally we're just not meeting people where they are, and demand that, moving forward. So we just have to think about this, and then partnering honestly across all these organizations too has to happen. I mean, I think even I'm so happy that Michael J. Fox, Parkinson, all of it, everybody's here, and we can hopefully just think about how to do this together to sort of move the needle if we're really going to do it. Because I think, little small changes are not going to add up in the way that if we just, as a community of people who care about Parkinson's patients and their loved ones, really are going to really be able to sort of bolster, like you said, the sort of energetic. I think the time is now. So how do we get this? So,
yeah, I think it's like building off of, right, like what Malcolm Gladwell said with like the tipping point, right? It's like increasing visibility. Let's start that first, getting on people's conscious, right? And then let's start, I mean, what we need is money, right? That's really, so whether that's fundraising, whether that's foundations putting out unique funding opportunities to bolster this work, supporting community agencies to do this, right? I've seen a lot from like the American Community Living Fund focused on dementia. Why don't we have that for Parkinson's yet? We need more advocacy. Let's be, get lobbyists out there so that the federal government will put more money towards Parkinson's. We'll put money towards addressing the needs of our communities living with Parkinson's, right? We need more of that. And so I think it's, really finding ways to push us past the tipping point so this can really just grow and meet the needs of people who need it.
Wow. Well, that's awesome. I will let that end on that note. And I think, the energy, this is Pride Month, but let's be Pride Year. Let's do it all day, every day. It just can't, the focus can't just be in June. I think it has to be, propelled through the future. And I'm excited to sort of continue the discussion and happy to help in any way. Thank you so much, Jason. I know it's been a busy month for you for taking the time to join us, and hopefully we'll partner together and I think that the audience is really resonating here. We'll put some resources in, and maybe we'll even write a blog and we can kind of share some resources there too, so we can share everything around. But thanks for joining us.
Yeah, happy Pride.
Woohoo! Thanks, Andrea. I'm going to pass it back to you to say goodbye.